All right, so now let's talk about tachyarrhythmia, tachycardia. Right? So we said this before, and we'll say it again. Tachycardia, the heart rate is greater than 150 beats per minute. Okay? And when we talk about tachycardias, there's two different types. We have it's called a narrow complex. I think that spray from earlier is residual on the board. Now I can't write on it.
Oh, that's nice.
Let's see here. Narrow and then wide. And you're going to see in your algorithms those two terms, narrow and wide. So when we talk about narrow, who can tell me what we're describing as being narrow? What is narrow? What specifically on the EKG is narrow? Who can tell me that?
The distance between the waves.
It's the width of the QRS.
Oh, yeah, that's
Okay? And sometimes they'll say narrow complex, wide complex, the width of the QRS complex. Okay? And that's important because if your QRS looks like this,
narrow.
this is a narrow complex. If the QRS looks like this,
It's consistent, yeah, but wider. Okay.
actually, yeah, more like this. And it's a regular, consistent, but they're wide, and you can kind of tell. I mean, there's definitions that say what's wide and what's not, but this is obviously narrow and this is obviously wide. And so when you're looking at the different things, generally, these narrow complexes with a heart rate of about 180, let's just say, is what we call SVT, supraventricular tachycardia, supra meaning above the ventricles. So when you say, oh, it's a narrow complex tachyarrhythmia at a rate of 180, you're thinking to yourself, oh, that's SVT, supraventricular tachycardia. You just know that. We talk about a wide complex tachycardia, and say let's just say this rate is 200, or let's say 180 or 200 beats a minute. If it's a wide complex tachyarrhythmia at a rate of say 200, and it's consistent, they all look about the same. It's called monomorphic. Can anybody tell me what that represents? What condition that is? VT, ventricular tachycardia. So we talked about SVT, supraventricular tachycardia, and VT, ventricular tachycardia. That talks about the origin of it. So in your SVT, the narrow complex tachyarrhythmia at about 180 beats a minute. SVT, supraventricular tachycardia, so it's coming from above the ventricles. VT, ventricular tachycardia, is generally wide complex, and you can have what's called monomorphic or polymorphic. What does polymorphic mean to you? What does that mean?
Not the same.
More than one change.
Yeah. So mono just means one, poly means many.
Mm-hmm.
Morphic means shape.
Or shape.
So one shape or many shapes. Okay? Now as we look at our let's start with the ventricular tachycardia or VTAC. So VT, ventricular tachycardia, it's generally wide complex. And so we have monomorphic or polymorphic. So your monomorphic might kind of look like something like this. Kind of like an undulating pattern where it gets kind of big and then little and then big and then little and then big and then little. Historically, that's been one of the trick questions on ACLS. They'll say polymorphic VTAC. That means torsades, de point. That's French. torsades de pointes, torsade de pointe, is a polymorphic wide complex ventricular tachycardia, and the treatment for that is magnesium. Well, they took that off of the ACLS. Although they still might ask some questions about it on the ACLS pretest, but for your guys' sake, that's all you need to know about it, and let's just move on. Okay? But if you ever hear polymorphic VTAC, that's what that is, torsade de pointe. French.
Yeah.
Français. Je ne sais pas un croissant.
Really?
Not a croissant.
Really?
Je m'appelle.
There you go, yeah, that's all I know.
Or there's that famous song, Voulez-vous coucher avec moi?
Let's not do that, sir. Not today.
Alright, anyway, VT, monomorphic. That's basically just kind of looks the same. Now you might be asking yourself, well, how is that any different from VFib? Well, VFib is kind of a little more jagged and erratic. You know, it's not the same. Now with VFib, you might have something a little more coarse, but again, it's not that consistent, wide, complex, regular, monomorphic. It's the same every time. There might be some slight variation, of course, when they show you the strip on the test, but monomorphic VTAC kind of looks like that. Most of the time, if you see this monomorphic VTAC, especially during your mega code, it's going to be pulseless. Pulseless VT, pulseless VTAC. And if you remember on your algorithm, pulseless VTAC is treated the same as VFib, right? So when you look at your algorithms, you'll see PVT/VF. It's basically the same. So if you look on the monitor and it has that wide complex thing and they don't have a pulseless VTAC, it's CPR, shock, 2 minutes, CPR, and then you reassess, shock, epinephrine, so on and so forth. So that's your wide complex tachyarrhythmias. For the VTAC, ventricular tachycardia, and you might see on your pretest or on your actual test maybe some questions about, well, how do you manage VTAC? If they're in VTAC and they have a pulse, that's seek expert consultation, and that's the extent of what you're going to worry about with ACLS. All right, narrow. Your narrow complex tachycardia is generally SVT, supraventricular tachycardia. If you look on that book there at the very bottom page, I think that should be SVT, that little narrow complex consistent. You generally don't see a P wave. You might, but the P waves kind of disappear. Oh, for the camera? No, that's okay.
Okay, alright.
Generally, you don't see a P wave, but it's kind of, it disappears in the thing. So it's just, you'll see that it's just, you know, tacking away is a way of describing it. Rate. Yeah, maybe it'll merge together, or it's just, you just can't see it. But SVT, supraventricular tachycardia, you know, that's when your rate is greater than 150, but it's usually less than 200. And so when you're looking at that little box technique, you'll see one like at this first box, and the second one will between somewhere inside of that second box, because at this point it'll be 150. I'm sorry. Yeah, 300, 150, right? So if it's in that second box, it's greater than 150 when you're looking at the thing. But it'll be pretty obvious to you that it's a narrow complex tachyarrhythmia with a rate of about 180 is the usual thing. So when you have a narrow complex supraventricular tachycardia at a rate of about 180, and you look at your algorithms, we talked about that previously, you have to decide, are they stable or are they unstable? Do you need to treat them right away, or do you need to like give a little bit of time and try something not quite so invasive? So we talked before about the signs and symptoms of instability. Remember, it's altered mental status, confusion, maybe they're semi-conscious, they've got some ischemic chest discomfort, low blood pressure, hypotension, all that stuff. So if they're exhibiting those signs and symptoms, they're unstable and they have a narrow complex tachycardia at a rate of 180, what's the treatment? Say it louder.
I said shock.
She quietly said shock 'em. No, you have to shock 'em!
I'm like, no, because I was writing down, I'm like, I
You
don't
shock
think I missed anything. Okay.
Yeah, sorry. So specifically, do you defibrillate?
Yes.
No.
No. I don't defib.
Defibrillate is only for ventricular fibrillation, right?
I thought we were just talking about that.
Yeah. So the shock that you deliver, is it defibrillation? Is it synchronized cardioversion? Synchronized cardioversion, right.
Oh.
So basically, you have to synchronize where during the cycle it'll deliver the shock, because if you deliver it at a point outside of this QRS complex, you can put it into cardiac arrest. Question: did you guys all get the swank training on the Zoll?
EKG, I haven't done it yet.
I haven't done it yet.
There's like 10 modules or something
Yes,
like that.
sir. I've
Well-
got 50 emails about it.
Yeah. Well, I'll tell you what.
Is that
It's actually.
Helpful?
Yeah. It'll make more sense after you take your ACLS class when they're actually giving you hands-on stuff.
That's good.
It's going to, the things that they're going to be throwing out to you, I think you're going to understand more than those who are not doing this. They'll be like, what? Synchronized, huh? But pay attention, actually, this is a good opportunity for you to get a little bit of extra learning. Instead of just clicking through the things as quickly as possible, use it as a good learning opportunity, because a lot of these concepts, it'll help reinforce that with you. So I would encourage you to take your time with it. Okay. Not that anybody just clicks through slides, right?
I have no idea what you're talking
Wouldn't
Sir.
say that. Don't say that on video because.
Sir.
about. Oh, is that him?
Anyway, all right. So synchronized cardioversion. So you want to deliver that shock. There are signs and symptoms of instability, unstable tachycardia. Shock 'em. That's the answer. So in real life, they're unstable, and it's taken some time to get the thing together or synchronize it or whatever it is you got to do. You can still do the other maneuvers. If they have cognizant enough to try vagal maneuvers, sure, try it. If you have that medication right on hand and it's going to be quicker than delivering that shock, okay, try it. But the answer is synchronized cardioversion. So what's that other medication that you can give them for this tachycardia? Adenosine. What's the dose of adenosine?
6 milligrams, then 12 milligrams.
6, 12. And it's a media IV push. The trick with adenosine is, you want to get as close to the heart as possible, so ideally the left AC, as opposed to, say, if they have an IO. But if that's all they have, then that's all they have. But you want to give it a quick push, and the trick with it, if they're conscious, you have to warn them, hey, this is going to feel funny, because their heart's going to stop. And on the monitor, it'll just kind of like stop. And then it'll restart again. Okay? So maybe for a few seconds, and they'll feel like, oh, what in the world was that? So adenosine. So you want to tell them in advance, hey, this is going to feel funny, but we've got to do it. 6 milligrams and then 12 milligrams. Vagal maneuvers. So those are the things that you want to do if they're relatively stable. Maybe they got a little fluttering in their chest. Maybe they just feel funny, but they're normal intensive. They know where they are. They can talk to you like in a normal sentence almost. Okay. Encourage them to try to do vagal maneuvers while you're getting the IV and trying the adenosine. But if they're stable and they've got this, don't chop them. Try the other measures first. Okay. Questions about that? Okay. All right. Let's stop this here.